our next session is fertility and reproductive health. It's an often confusing and emotionally complex topic. It's normal to have questions about how bladder exstrophy affects fertility potential, pregnancy, and family planning, but it's not always easy to find clear answers. We're fortunate enough to be joined by, that's my son right there, by two outstanding clinicians. Dr. Daniel Pelzman, a urologist specializing in men's health at Massachusetts General Hospital, will speak about male infertility.
All right, so I'm Dan Pelzman. As Dr. Lee mentioned, I'm a urologist, and my interest is in male fertility and infertility. So I'm going to talk about fertility considerations for patients with bladder exstrophy. I just wanted to start with this slide because I think this was a pretty impactful statement. This was from one of our American Urology Association updates from a few years ago. But the reason why I'm giving this talk is because adults with a history of bladder exstrophy can have satisfying sexual function and can successfully conceive children. On the male side, males can go on to father children, but a lot of them will require ART or assisted reproductive technologies, which I'm going to talk about later on. I just wanted to really briefly talk about male reproductive physiology because this will inform a lot of the next slides. So really briefly, sperm are made in these tubules within the testicle called seminiferous tubules. They then the sperm travel into the structure called the epididymis, which is right next to the testicle. From the epididymis, they travel up the vas deferens, and the vas deferens carries the sperm into the abdomen, where the sperm meet with fluid from the seminal vesicles, which is near the prostate, and that is what forms the components of semen. Semen is then ejaculated out the urethra and out the penis. Now, the challenges in patients with bladder exstrophy, it's not really about sperm production. So while some patients will have hormonal problems, just like patients without bladder exstrophy, sperm production in general is not the important topic of discussion here. Rather, there are a few challenges that we face, which I'm going to talk about here. One of the challenges is something called retrograde ejaculation, and this is where semen travels back into the bladder due to an incompetent bladder neck or abnormal bladder neck function. So during normal ejaculation, the bladder neck squeezes, and then semen can be propelled outward. For patients with bladder exstrophy, often the bladder neck can't do that, and so the bladder neck stays open, and the semen is deposited into the prostate and into the prostatic urethra, where it then just falls back into the bladder. So very little semen comes out. Another challenge we see is obstruction of the vas deferens or the epididymis or the prostate. What that can cause is, well, now the sperm just cannot actually get out into the urethra. This can be due to a number of different reasons. Some of the reasons that I've mentioned here are, well, if you've had pelvic surgery in the past, especially surgery near the bladder, sometimes that vas deferens can either be injured or there can be some scar tissue that compresses it, okay? If you have a history of UTIs, sometimes the prostate can get some scar tissue in the ejaculatory ducts, which prevents the sperm from traveling out. Other times the epididymis can also be obstructed. The epididymis has a lot of very, very tiny tubules, and so any infection called epididymitis can block those tubules and prevent sperm from reaching the urethra. And then lastly, sometimes there are challenges with sexual intercourse, which was mentioned in the last session, and this can be either due to anatomy, sexual dysfunction. So I'll talk about how we can address those. The other thing I wanted to talk about is assisted reproductive technologies, or ART, because when we talk about solutions for these problems, then it's important to understand these. There are really three types of conception that are available to us. One is unassisted or natural conception, and this is your typical sexual intercourse where sperm are ejaculated into a uterus and the sperm go up and fertilize an egg. Intrauterine insemination is a procedure done by fertility laboratories. It's colloquially known as the turkey baster method. This is where we take the best moving sperm and we put that into the uterus at the time of ovulation. This relies on the male having at least several million moving sperm. But this is a slightly less invasive technique than IVF, which is in essence the most invasive technology that we have. With IVF, we take sperm and then one egg, and there are two types of IVF, classical or ICSI, intracytoplasmic sperm injection. With classical IVF, we just take a bunch of sperm, put them in a petri dish next to an egg, and then hopefully an embryo develops, and that embryo is then transferred into a uterus. With ICSI, which was developed in the 90s, we take one sperm and one egg, and we just put them together. And once again, hopefully an embryo develops, and then that can be transferred into a uterus. So what can we do about these challenges that we face? Well, first of all, it's important to know that 10 to 20% of males with a history of bladder exstrophy actually have no issues with fertility, and they can conceive without any ART. So I think it is worthwhile, if you're interested in family building, to at least start trying without needing to really get engaged with a fertility specialist. And 10 to 20 people will not have any problems. If retrograde ejaculation is present, then there are a few options that we have. One is we can have the patient ejaculate, and then we obtain a urine sample from the bladder. So this does rely on you having an intact urethra and bladder. And we can extract sperm from that sample to then go on and do IUI or IVF. There are also some medications that I frequently prescribe called imipramine and pseudoephedrine. And what those do is they work by squeezing the bladder neck. Now, when I was doing research on this subject, I actually did not see any publications about the use of these medications in patients with bladder exstrophy. This might be an area of research, and I'm happy to talk to one of the pediatric urologists about their experience, and if that's something that we should look at. And lastly, another option would be retrieving sperm from the testicle for use in IVF. If there's an obstruction present, then the gold standard is really to do a sperm retrieval from the testicle. Remember, the testicle is still making sperm, so we should be able to obtain sperm from the testicle and use that for IVF. Lastly, if there's a problem with the ability to have intercourse, then depending on sexual function, we can either do a sperm retrieval, once again for use with IVF, or we can collect a sample with self-stimulation and use that with IUI. I wanted to briefly talk about sperm retrieval techniques because if you're interested in family building and there are some problems and a urologist counsels you about these options, I want you to be familiar with, there are really three options that we do. One is called a TASA, or testicular sperm aspiration. And this is where we just put a needle into the testicle. The testicle is numbed up before we do that. And we retrieve a bunch of seminiferous tubules. That is processed by an andrology lab, and the sperm are used for IVF. This can either be done in the OR or in an office. There's something called TESI, or testicular sperm extraction. This is where we make a small incision in the scrotum, and a tiny segment of the testicle is excised, once again processed by an andrology lab, can be done either in the OR or the office. And then another option is MESA, or microsurgical epididymal sperm aspiration. This requires a larger incision, but we actually go right to the epididymis, and that's where sperm are more concentrated. So we can incise that and obtain a bunch of sperm for use with IVF. This is usually done in the OR because it requires a bigger incision. The takeaway from this slide, though, is that they're really all equally effective at obtaining sperm. The decision for which one of these to choose is largely based on the capabilities of the andrology lab. So for example, some labs just don't feel comfortable using testicular sperm. They want to use epididymal sperm. It's more mature, it can move. And it's also based on provider experience. So for example, I typically do TASAs and TESIs. I've seen maybe one MESA in my life, whereas some of my colleagues in the same field, they almost exclusively do MESAs. It doesn't really matter. Okay, so in conclusion, a significant portion of patients with bladder exstrophy will have no problems with fertility. And so it is important to practice safe sex if you're not interested in conceiving. For patients with retrograde ejaculation or problems with intercourse, then IUI or IVF are potential options, and they have relatively high success rates. There may be a role for medications in the setting of retrograde ejaculation as well. And then for patients with obstruction, really sperm retrieval is the gold standard, and those sperm would need to be used for IVF. IVF success rates are pretty high. Thank you.
Thank you so much. So Dr. Nicole Smith wasn't able to be here, so I'm going to briefly present on the topic of female fertility as well as pregnancy-related issues. So fertility, you got to start thinking about the head down. So you're thinking about, are the hormones that you're producing to stimulate ovulation, is that normal in patients with epispadias and bladder atrophy? Yes, it is. And the ovarian function is also normal. So then you're going to undergo normal menstrual cycles because your uterus is typically a single system and it's not blocked. So women with bladder atrophy are typically just as fertile as women without bladder atrophy. Yeah, the story is a little different in patients with cloacal atrophy. So there are patients in the room with cloacal atrophy. The hormone function is normal. The ovarian function is also normal. But in terms of the uterus, it is typically duplicated. The vagina is typically duplicated, and the cervix that's in between the vagina and uterus is sometimes incompetent, meaning bacteria that goes in the vagina can easily ascend into the uterus. And a lot of the times, the vagina is not reaching the outside world. So it's two systems that are inside the body. This is super important in terms of fertility, but also leads to a lot of pain, as well as infections during the pre-pubertal period, often misdiagnosed as urinary tract infections. So we actively try to engage pre-pubertal patients with cloacal atrophy and preemptively look for signs of puberty to understand, because that's when we can start assessing the anatomy to see how many systems there are, how far is it located, when is the best time to remove these structures. When we remove these structures, we need to organize and plan for surgeries in other systems to make sure that we combine these surgeries to minimize the total number of surgeries patients get. So these are some of the things that I think of when I'm seeing patients with cloacal atrophy. And then in terms of pregnancy and delivery for classic bladder atrophy and epispadias patients, I expect patients to have successful pregnancies with healthy babies. In vast majority of patients, the chances of a patient with bladder atrophy or epispadias, both male and female, passing on their risk to their offspring are extremely low, because the risk is so low at baseline. If you have a 4 or even 40 times higher risk of passing on, that's the estimated risk based on some limited studies. Even if your risk of passing on bladder atrophy is elevated, that total number, absolute number, is quite low. So, for example, if you have a 50% chance of passing something on and you double that risk, that's a really high risk. But if you have a 1% chance or 0.001% chance of passing something on and you double that risk, it's still really low. So for patients with cloacal atrophy, it's a very complicated topic that I think essentially pregnancies that are carried to term in cloacal atrophy patients are like case reports, meaning 1 or 2 and written in the literature. So it's very rare. So other pregnancy considerations in patients with bladder atrophy, we discussed the elevated UTI risk. For patients with cotton catheterizable channels, There can be increased risk of difficulty with catheterizations because the uterus, as it expands, it is going to make the channel get displaced and disfigured. Usually it's temporary, but it can last up to a month after pregnancy. So a lot of patients keep their channels catheterized with a tube for about 3-4 weeks after pregnancy. A lot of patients experience blocked kidneys, hydronephrosis. We see that in patients without bladder atrophy because the uterus compresses the tunnel between the kidney and bladder. It can lead to some dilation of the kidneys, like plumbing, and that often happens in patients with bladder atrophy, which can increase the risk of stone formation, infection risk, as well as sometimes pain. And then pelvic organ prolapse. Patients with bladder atrophy have, I would say, a very elevated risk of pelvic organ prolapse. That's when you can have the uterus, bowel, or bladder come out through the vagina. You can visualize those organs through your vaginal opening, and that risk is elevated during pregnancy. For delivery considerations, because of that pelvic organ prolapse, actually, patients tend to not struggle during vaginal delivery. As a urologist, I think as surgeons, we always think about ourselves first. That was a joke. Nobody laughed. So when we do bladder neck reconstructions, we are operating on the urethra that sits right above the vagina and the uterus. And when that during vaginal delivery, with stress, we fear that our reconstructions can be compromised, stretched, or torn. So as a urologist, I often say, hey, I really would prefer that you do not undergo vaginal delivery. But when I spoke to Dr. Smith, she said, actually, that's something that we discuss with patients often because the pelvic muscles are quite actually stretchable, and the harm to the pelvic structures during vaginal delivery, Dr. Smith thinks, is less. So it's I think a discussion that we need to have with the urologist, the maternal fetal medicine doctors who were basically the obstetricians or the high-risk obstetricians, and the patient need to have a discussion. Hey, you had a bladder neck reconstruction. You're pretty continent right now. You only leak a little bit when you're jumping, sneezing, coughing, but you're able to hold your urine. If you undergo your vaginal delivery, you may have injury or increase in distress urinary incontinence. What do you think? Is vaginal delivery important for you? Those conversations need to happen, I think, earlier on during pregnancy. If you have a continent catheterizable channel, it's probably a good idea to do a midline incision, meaning not sideways, but up and down, to make sure we don't injure the blood supply or the channel itself. And that we discuss leaving the indwelling catheter in the channel for at least a couple of weeks. Thank you. We're gonna forego the question and answer during this session because we're running behind. I'm very sorry.